going to be talking about case management as it relates to mentorship, education, and chronic care management. And I'd like to introduce John Heraty, who is our CMSA Chicago President-elect. Welcome.
Thank you, Doctor.
Okay, and John is a wonderful social worker in managed care. And then we have Colleen Morley, who is also here, who is our CMSA Chicago President and USA President-elect. So I'm surrounded by a lot of presidents here today, so this is quite exciting. Congratulations.
Thank you.
And then we have Trish Benson, who is our former Chief Operating Officer of Transitions Home Medical Group, which contains our Palliative Care branch, and now she is the President of Transitions Home Medical Group. So as you see, I'm surrounded by presidents. Welcome, Trish.
Thank you.
So we're going to start with interviewing Colleen on how basically, chronic care management relates to case management in her field. So go ahead, Colleen.
Oh, wow. What can I
It's a
tell you
broad
about chronic
topic.
care management? So I've been working, we've been working with readmissions since 2009. It became a really hot topic in 2009, which coincided with my return to the acute care side of case management. So readmissions, we're looking at chronic condition management, we're looking at our congestive heart failure patients, our chronic obstructive pulmonary disease or COPD patients, our end-stage renal patients, so conditions that will continue on with the patient from the time of diagnosis on to when they leave this world. And we're looking at how we can reduce the readmissions to the hospital by making sure that they have everything that they need to be able to be successful when they go home. And that, we're still looking for the secret sauce. We're still looking for what's the magic ingredient here.
Mm-hmm.
And there's a lot of work that's been done. If you Google readmissions since 2009 under scholarly articles, there are over 12,000 different articles and projects that have been happening since 2009, just trying to address how are we going to reduce readmissions. And there's lots and lots of different programs that are out there. There's transitions programs, there's Project Red, there's the Transitional Care model, there's lots of formal big projects out there. There's also some studies that have shown that a lot of facilities look at these different models that are out there and they pick a piece from this and a piece from that, whatever is going to fit their population,
Mm-hmm.
and they create their own little hybrid model. So they have their own hospital-specific models that work with this. Whether it's putting 30-day transitional programs in place, whether
Mhm.
it's doing extra education, we're still trying to figure out what the secret sauce is as to how are we going to reduce readmissions.
Mhm.
And that's really the best management that we can come up with right now for our chronic care patients, because we've got patients who come in at a stage 1 of congestive heart failure and they go all the way through stage 4, stage 5s, if they're stage 5 now, depends on which one you're looking at.
Mm-hmm.
How are we educating our patients on what to expect, and how are they prepared, and do they feel confident enough to manage their care at home? And the reason that patients are coming into the hospital, from a lot of the research that we're seeing, is that these patients are not confident to take care of themselves at home. They don't know what to do. They're they get short of breath. I don't know if I have asthma. When I get short of breath, I get a little panicky too. And my first thing is like, hey, I need some help.
Mm-hmm.
If you're getting short of breath like that, and you end up in the emergency room because you want somebody to fix this problem for you. Unfortunately, these are chronic conditions, so this problem is not going away. And what we need to do
Right.
is come up with management and including that patient into how are they going to manage it, and educating them on how to take care of themselves.
I think that's a very good point you bring up, is the autonomy of the patient. Not only the autonomy, but the part that they play within their own management and empowering that. How do you see that the social work and the nursing piece fit in from a case management perspective in chronic care to make that happen? We have our way we do it, but how do you accomplish that?
I think from an acute care perspective, really understanding where the patient is and if the patient can, health literacy. It's my newest soapbox. It's one very, very dear to my heart right now. Really recognizing that we have a tendency as healthcare providers to speak in a language called medicalese. that the patient does not understand and
Sure.
does not have a translation. There's no Google Translate for medicalese. That we have a tendency to send people home with 4 inches of, discharge instructions and medication monograms and all their instruction. Oh, here's a 4-inch thick thing about how to take care of your disease management, and you've got 4 or 5 different diseases, so they give you the monographs on every one of the diseases and
Right.
the monographs on every one of the 15 different medications you're going home with. So it just keeps piling up and piling up and piling up.
Right.
And it's written in a way that lay people can't read it. So they go home and they've got all this information and they're overwhelmed. And what do? They take it and they put it in a drawer.
Right.
Or they take it and they put it under a plant to absorb the water, like the one gentleman I talked to did. So we're not doing them a service by over inundating them with too much we're giving too much information.
At once.
It's
Yeah.
totally a TMI, and it's totally in a way that they're not able to digest it. Small bite-sized chunks
Mm-hmm.
in a way that they can understand it. And I think John will agree with me when he's
Great.
doing his telephonic outreaches.
Mhm.
He's not talking to them in medicalese.
Right.
Right. So, yeah, and I'm fascinated by all that because it's a very complex.
You're very interesting.
And what was going through my mind when I was hearing Colleen talk about all these things and all the scholarly articles is that, number one, it costs a lot of money to help people. Number two, you have to have a stakeholder, okay? Like your parent, you're like, these are my parents, I gotta take care of them.
Mhm.
Who are the stakeholders for people that they don't have a lot of family?
Sure.
And I'll just say this, as a managed care social worker, this is just from the managed care perspective, health insurance companies have a stake, they have skin in the game, okay?
Mhm.
Because these are our members. If they go to the hospital, we pay for it, okay? So that's why they call it managed care. So what we wanna do, and the game is changing so rapidly, like at CVS, what you're gonna wind up having is life preservers all over to say health hubs, right?
Mhm.
So it's like a CVS, instead of having, they're gonna cut down on the Snickers, I can't speak for CVS, but you'll probably wind up seeing less Snickers and Milky Ways and more health bars, dialysis, advanced practitioners, social workers. So there is a lifeline where these folks, instead of going into a scary emergency room, they can pop, down the block and go to a CVS. Or I could call them, or a nurse could call them, because we're advancing virtual care, right?
Right.
And virtual care, you could literally talk to somebody for a minute and do a course correction. One of the things we do is that it's a psychosocial assessment, but its basic things is, are you lonely? What do you do for enjoyment? Colleen told me that her hobbies saved her dad's life.
Mhm.
We can't forget about all the different things that make up a person. And when you start asking them, are you lonely? Or what do you do for enjoyment? You start building more and more of a connection, which reduces readmissions to hospitals.
That's amazing. You bring up some very good points as well. I think that, the way that you do it is very comprehensive. And how often are you outreaching to the patients, or does it really depend on what program it is?
It really depends on what program it is. And programs that I've put together at several different area hospitals here in Chicago, we've got a nurse and a social worker working together, reaching out to the patient. They would reach out to the patient within the first 48 hours of discharge, go back over the discharge instructions, make sure that they understood everything. Did you get your medications? Can you not get your medications? We can get them delivered to your house. A lot of gap finding. And then we would set up weekly phone calls, and the patient always had the opportunity to call directly. We had a direct dial number for that nurse and social worker team.
Perfect.
So the patient could always call back and find, hey,
Right.
I'm having some issues with this, or I don't understand that. But each time that they were calling, they were doing gap finding. Okay, your follow-up appointment is on Tuesday. I'm gonna call you on Wednesday. And they call on Wednesday. Oh, you didn't make your appointment on Tuesday. Well, what happened? Oh, you didn't have transportation tweaked out at the last minute. Let's go ahead and remake that appointment. And you know what? I'm gonna set up transportation for you because it doesn't sound like you've got a somebody that can take you whenever you need to go.
So that engagement with the patient allows for best care and obviously reduction of readmission. Now, in our world, in our palliative care, chronic care management world, we echo some of the way that is done. And so I'm going to have you go ahead and interview us.
Great. All right, so we're talking about chronic care management. How does Transitions engage with chronic care management? I know we talked a little bit earlier about palliative care, so tell me a little bit more.
Right, a very large percentage of our palliative care patients are enrolled in the CCM. So the chronic care management piece of that is performed by coordinators on our team. And they're making those phone calls, they're touching base with the patients, and they're finding out, they're looking at their plan of care and their medication refills need to be made. And that really does help staying in connection. It helps avoid some of the rehospitalizations. These phone calls are made monthly, and they do spend the 20 minutes at a time with the patient, just going over some of those details. And then, Doctor, you can elaborate a little bit on that as well.
Right, so, and there's definitely that transitional care component of when they come out of the hospital, where we're going to capture, the needs of the patient. And as Trish mentioned, then there's the chronic, care management piece that, envelopes the patient. And as these patients that have serious illness become more acute in their illness, they become a kind of acute palliative care patient, which we, talk about these patients monthly in each of our areas that we have a nurse practitioner overseeing. And then there's physician oversight, and part of that team, for our palliative care team, Trish can, kind of elaborate on that.
Yeah, the palliative care team actually it's a lot different than what you would typically see. I feel in a palliative care team, it's overseen by our doctor or doctors that are in the areas that we service. And then we have the nurse practitioner who is managing the care for the patient. The nurse practitioner works directly with the patient's primary care provider. So we're always in communication and working side by side with them on that patient's needs for the chronic illness that they may have. We also have the social work component, so the psychosocial needs. Nurse practitioner may do the assessment, do the follow-up visits, and see that that patient and or their family may need some support that the social work or the licensed clinical social worker, in whatever case it may be, can assist with. On top of those 3 members of our team, we also have the RNs available. So in palliative care, typically, what you've seen maybe is a monthly visit from a provider, or maybe even one visit every couple months, depending. We enhance that. We're looking at seeing our patients, as much as possible, whatever that medical need may be, but we can incorporate the RN to come in and see the patient as well. And what happens is, say a patient who typically is having some sort of change of condition, they would result in a 911 phone call and could be an unnecessary ED visit. That could lead to a readmission to the hospital. What we provide is call us. We can send a nurse out right away, do a quick assessment with the patient, talk to the family, what's going on, and then that nurse will communicate directly with the nurse practitioner that's available. It may trigger a telehealth visit, so the nurse practitioner is not immediately available in that area to do the in-person visit. That nurse will be, because we have nurses stationed in all the areas that we service. And then she or he may call the nurse practitioner to a telehealth visit that can result in not having that emergency room visit.
Is there a certain criteria set that a patient needs to meet in order to be enrolled in your chronic condition management program?
They do. So there has to be 2 chronic care illnesses. And Doctor, could you elaborate a little bit more on that?
Right, so they have to have at least two serious illnesses, which most of our patients obviously do, so they're gonna have the COPD and the hypertension. Many of these are long-standing conditions they've had that they know will progress. And as you do in your case management world, and in many of the case management worlds, we oversee these patients with the frequency that they need and with the resources that they need. We also are very progressive at this company, and we have tools that we use that really help with our outreach.
Right. So on top of the chronic care management, we also can do the remote patient monitoring. So we work with an organization that provides the patient with digital devices such as the pulse ox, the blood pressure cuff, the weight scale. So we are able to monitor all of that data on a daily basis, But it also allows the patient to monitor their own health on a daily basis as well, without having to go into the clinic or the ED or
Active engagement.
Right.
Yeah.
And what we have seen with utilizing these devices is with us being able to see, you know, there's a sudden weight gain or weight loss or something that comes back that triggers us to send the nurse or the nurse practitioner, we're able to connect with that patient right away. And again, it triggers the telehealth visit.
Wonderful. Let's see, so we talked a little bit about keeping readmissions down, so how successful have y'all been in keeping the readmissions down?
Actually, I have some data here I can share
Yeah,
with you.
I love data.
I was just thinking about
So,
that.
when we are informed of a discharge, we contact the patient within 24 hours of being informed. Check on them, how are things going? When we are informed, 85% of discharges from patients and families or other agencies, we are able to conduct that transitional care management piece, which Dr. Kapur was speaking of, for 98% of those patients.
Wow.
80% of which are seen by a provider within 1 to 7 days from that discharge, and then remaining are seen 8 to 14. So by us implementing that transitional care piece into our service line, the rehospitalizations have decreased tremendously as
The
well.
gold standard for that first follow-up visit after hospitalization is within 7 days, and you guys are hitting the mark.
Yes. So 98% of the patients that are not readmitted to the hospital they were not within the 30-day period. So in 2020, Transitions Home Medical Group was able to save $22 million on total cost savings for rehospitalization.
That's impressive.
And we're just gonna continue to grow and increase
Mhm.
those numbers in 2021.
To John's
And-
point, skin in the game, right?
Yeah.
Yeah.
And just improving the type of analytics that we're using, and our company tries to stay on the cusp of what is the best resources and to kind of give the patients the best care. So
Well, I mean, readmissions is a huge issue with the hospitals because of, penalties and all these other wonderful financial things. But at the end of the day, it really does come down to patient-centered care. It really comes down to the fact that nobody really wants to be in the hospital. And if we're not equipping our patients well enough that they're at home and they're confident enough to take care of themselves, they're gonna end up back in the hospital. And therefore, the definition of readmission from CMS is a failure of the discharge plan. And as a nurse, personally, I take that really personal because discharge planning has always been the bailiwick of nursing. And you're telling me that we failed? Well, no, we're gonna throw down on that. We're gonna make sure that this doesn't happen anymore. So,
Mhm.
absolutely. Congratulations on those numbers
Thank you.
and those outcomes.
thank you.
Recently, we've been recognized, with some of the positive outcomes that we've had, that it's really led us to new partnerships. There's different oncology groups in the area, hospitals in certain areas that we service that have recognized the quality of care we're providing, and they want to work with us, so it's really helped.
Our growth has definitely has happened because of that, excellent care and word of mouth, and so we want to continue to provide that excellent care.
Wonderful. Excellent.
Thank you very much for joining us.
Thank you.